Hey guys, hope you're doing good. Today I'd like to discuss about this topic, occlusion in removable prosthodontics. You guys know that this is one of the most important topic for you because in clinics, it's just not about the complete dentures, but I'm sure you know that you come across a lot of removable partial denture cases, and I'm sure that every part of this topic that's been discussed is quite important for you practically. So please do pay attention, and if you have any doubts, please do revert back to me either via your comments or through email. So in this lecture, I would like to mainly focus on the natural and artificial occlusion. Then we'll try to speak about the errors in occlusion, then the methods of establishing occlusal relationships in your RPDs, and what are the different causes of errors in the occlusion, then the methods for occlusal disharmony, and also about selective grinding for the anatomic teeth. So to introduce the basic terminology that you would be coming across in this particular topic of occlusion is, I want you to be familiar with occlusion, maximum intercuspation, centric occlusion, centric relation, and terminal hinge axis. So occlusion is not a static relationship. I know, right, from your year 1 to year 3 or in your year 4 in orthodontics, you must be just coming you just keep memorizing on this part, and you think that occlusion is nothing but the contact of your maxillary first molar, the buccal cusp of your maxillary first molar, and the mandibular first molar, right? So, but that is something to do with a static relationship. But to define the concepts of occlusion, it is something more than just the static relation. Okay, I would rather say that it is a dynamic relationship between the incising and the masticatory surfaces of the maxillary and the mandibular teeth analogs. So, what happens in your maximum intercuspation? It is the complete contact of both your upper and your lower teeth, and it is independent of the condylar position. So you know that your masticatory process, the mastication that occurs between the upper teeth and the lower teeth are all together working along with the temporomandibular joint, right? So, but in your maximum intercuspation, like when you see in a cast, when you try to occlude an upper cast and a lower cast, all that you see is whether the upper teeth are coming in contact with that of the lower teeth. You're not looking at the patient's condyle. The TMJ is not taken into consideration. So your maximum intercuspation has got nothing to do with that of your condylar position. And then coming to centric occlusion. So centric occlusion is nothing but when the mandible is in the centric relation position, and this may or may not coincide with that of your maximum intercuspation. So your maximum intercuspation is, I want you to imagine you have an ideal cast of the upper and your lower, and all the teeth are present. So how do you occlude it in a class 1 position, right? So you see that the maxillary first molar is coming in contact with the central groove of the mandibular mandibular first molar, right? So that is something to do with maximum intercuspation. But in your centric occlusion, please notice that it is something to do with that of your centric relation position. So here comes the concept of the importance of the position of the condyle in the glenoid fossa. So then, and now what is centric relation? So centric relation is the most comfortable, superior most, anterior most position of the condyle in the glenoid fossa in simple terminology. And to define it, it is supposed to be the most retruded physiological relation of the mandible to that of the maxilla. So mandible as such is one complete bone which is articulating and functioning and gliding over the glenoid fossa of the maxilla, right? To and from which the individual can make all the collateral movements. So when it is in the most comfortable position, that is where the mandible is in the correct position, and it's a condition that can exist at various degrees of jaw separation, and it occurs around a terminal hinge axis. So now what is this terminal hinge axis? So if you can imagine the condyle, right? So just imagine that we are drawing a line on the center of the condyle of the mandible. So the line passing through the center of the condyle, and this is the terminal hinge axis. So this is an imaginary line around which the mandible may rotate within the sagittal plane. So you all need to know that there are different kinds of movements that the mandible will usually be undergoing, right? In the sagittal plane, in the frontal plane. So translatory movement, rotatory movements, that's completely a different topic as such, but you should be aware that it's just not your open and close movements, just like how you see in a mean value articulator, but it is beyond that, because your condyles in the glenoid fossa don't just open or close, they glide in different positions. Okay. Yeah. So let's look at the differences between the natural dentition and the artificial dentition. So in your natural dentition, as you see on the slide, it is having a periodontal ligament, then the teeth will move independently, right? So there is some amount of physiological movement that occurs in a natural tooth, and it has got nothing to do with the adjacent tooth. And then next is the malocclusion. It does not affect immediately. You would have seen couple of patients in the OPD, patients who have severe malocclusion or even a mild malocclusion, but their malocclusion does not cause any kind of deterioration to the maximum, and they do function quite normally even without undergoing any orthodontic treatment. So whereas in comparison with your artificial dentition, uh, your dentures are supported by the mucosa, which is a movable tissue, right? And here your natural tooth moves independently, and in your artificial dentition, it is moving as a complete unit, right? So the removable partial denture or your complete denture functions as one unit, one single unit. Okay. If there is any malocclusion in your artificial dentition, as such there is a premature contact or something, then definitely this malocclusion affects the entire base, and the occlusion is affected. So, and in your natural dentition, non-vertical force affects only one tooth. If there is any tooth, if any forces from the lingual or the buccal or from the mesiodistal areas, these forces can be tolerated well by that particular single tooth. But whereas in an artificial dentition, if your complete denture or your removable partial denture is subject to a lot of forces by either vertical forces or buccolingual forces, what happens is there is commonly dislodgement of the denture from the mucosa. So in your natural dentition, when you're incising, it doesn't affect the posterior. So when you're biting and you're using your anterior teeth to bite something to incise, what happens in the posterior? There's just a gap. There's just an opening in the posteriors, and it's got nothing to do with the posteriors. There's nothing that's happening. But whereas in your artificial dentition, if you're trying to bite on the anterior, sometimes it causes instability of the denture place in the posterior. So this is most commonly seen in your resorbed ridges, in your mandibular severely resorbed ridges. Okay. In your natural dentition, you have the tactile sensitivity, but in artificial dentition, if it's a partial denture or a removable complete partial denture, there is decreased tactile sense. So what can be done to achieve a satisfactory occlusion? First thing, so when you're looking at your patient, please analyze the existing occlusion. So when your patient is walking into your OPD, it's just not about just looking at the patient and saying, okay, this is a chief complaint of the patient. So one tooth is missing. So it's a good case for RPD or it's a good case for FPD. That's not the criteria. So when you're looking at what is missing, and what is the need of the patient. You should also analyze what is the kind of occlusion. If you're not analyzing the occlusion at your diagnosis, at the point of diagnosis, you might fail in giving a good prosthesis, because there might be supraeruptions or there might be very less intract space. So all of these things should be taken into consideration. There might not be any space also for giving a removable partial denture. So that is why you need to analyze what is the existing occlusion. Then if there is any occlusal disharmony, like the occlusal plane, or if there is a supraerupted tooth occupying the edentulous space in the opposing arch, then you will have to correct such kind of situations. Then recording the centric relation. As I mentioned, occlusion is not a static relation, but it's a dynamic relation. So you need to know the exact bite of the patient, the exact centric relation, the condition, the position where the condyle is in the most comfortable positions. Okay, and we should also record the eccentric functional relationships. Okay, and also correction of the occlusal discrepancies created in the denture. So if the patient is already an existing denture wearer, a previous denture wearer, then you will have to observe what is the kind of occlusion that has been given to him in the previous denture, and if it is not given according to the guidelines, or if there is any discrepancy or premature contacts, or if it's a monoplane occlusion, all these things have to be taken into consideration, and the same has to be corrected in your new denture. So in a partial denture, suppose if we have some natural teeth remaining, so that is either in the anterior or in the posterior, whether be it a class 1 or a class 2, class 3 or class 4, the remaining natural dentition will definitely have an impact on the kind of prosthesis that you're going to give for the edentulous areas. Okay, and your partial denture should always conform to the already established occlusal pattern. So if the patient is already having a class 2 relation, don't try and give him a class 1 occlusal relation, but you have to give your complete denture or your removable partial denture in the existing class 2 relation itself. You cannot change the bite of the patient. Just in case if you have not taken the correct bite of the patient, and if you're trying to establish a wrong centric relation, if you have not achieve the correct centric relation position, then definitely you are going to have a effect on the temporomandibular joint, and this might eventually lead to TMDs. So you must be mindful of the already established occlusal pattern which the patient is comfortable with. Suppose if you're looking at giving a removable partial denture which is opposing a complete denture, then your partial denture should be harmonized according to your complete denture. That is why you are advised to take an alternate impression of the patient wearing the complete denture, so that the same kind of a occlusion can be achieved with the new denture. In case if there are only anterior teeth remaining in both the arches, so if you have teeth present distal to the edentulous space and all the teeth are present in the opposing arch, then there might not be a need for jaw relation, but you can do a trial. You can do the teeth arrangement, you can articulate it, hand articulate it and mount, and then do the teeth arrangement. But if there is no tooth that is present in the distal most area, distal to the edentulous side, then definitely jaw relations is must. And then the main objective of your removable partial dentures is that you have to record the centric relation position, that is the most comfortable position of the patient, that is your TMJ is in health, and so that in this position the cast can be mounted on the articulator, so that the correct positioning of the artificial teeth can be done. That is when you are doing your teeth arrangement, your So if you are trying to hand articulate, you should, if you just look at it clinically, you must have observed that if you're trying to hand articulate your upper and your lower cast, you might just glide the cast like 0.1 mm or 0.2 mm, but this might lead to greater errors in the occlusion. So that is why you should always be clear about recording your jaw relationship and then mount your cast on the articulator. So this helps in establishing functional and a harmonious relationship in your RPT. And definitely, yes, you are helping in the preservation of the supporting structures, or otherwise a faulty occlusion can always have a negative impact on the supporting mucosal tissues. And so occlusion for a tooth supported removable partial denture, as mentioned, suppose if there is a tooth in the distal extension, distal to the edentulous space, it can be easily achieved because you have it is more of a tooth supported denture. But if it is only a tissue supported processes that you are constructing, then definitely you must be mindful of the different concepts of occlusion. Like an example, if it is a distal extension denture, and distal extension in both the sides, bilateral simultaneous contact should be present. If it is mandibular distal extension, so working side, here I would like to speak about working side contacts and non-working side contacts. That is the balancing side, non-balancing side. So the suppose imagine you are moving your jaw onto your right hand side. So the side to which the jaw is moving is your the working side, and the side from which the jaw is moving away is the non-working side. So in your mandibular distal extension denture, the working balancing contact should occur simultaneously, and so in the non-working side also there should be contact between your upper and your lower teeth. And yeah, if it is a maxillary complete denture and a lower removable partial denture, bilateral balanced occlusion in centric and eccentric positions must be achieved. I am pretty much sure that this is quite confusing. I would like to again go through this topic when we meet up for our practical session. So don't worry in case if you're unable to understand this particular topic. Yeah. So, and then your maxillary distal extension is just like the mandibular distal extension. In Kennedy's class 4, the contact of opposing anterior teeth in the plane intercuspal position is desired to prevent the continuous eruption of the opposing natural teeth. So, the overjet and the overbite has to be taken care in Kennedy's class 4. Then, artificial teeth must be arranged distal to the retromolar pad. So if there is an inclined plane, there is usually instability of the denture. So try not arranging teeth on the steep inclined plane that is in your distalmost edentulous space. Then looking at methods for establishing the occlusal relationship. That's in that you will come across the direct opposition of cast. So in the picture you see that the maxillary cast is articulated, hand articulated with the lower mandibular cast, and you see that there is this edentulous space is bound by tooth on either sides, right? So there is a teeth on the mesial side and as well as on the distal side, and opposing to this tooth you can see that there is uniform contact of the upper teeth with that of the lower teeth. So this is an ideal condition where you need not do a jaw relation, but you can occlude with your hand. This is for only single missing teeth or two missing teeth wherein all the opposing teeth are present and they are able to be occluded, or they can be held in the occlusal position without any movement, right? So that is direct opposition of cast. Then interocclusal records with the posterior teeth remaining. So if there are posterior teeth remaining, you will just modify the cast. So when there are sufficient natural teeth, like your Kennedy's class 3 and class 4, you don't have to actually take the jaw relation, but what you can do is either use an interocclusal material like wax, aloe wax, bite registration material, that is your silicons. These are specifically used to just record the bite. So what you do is you dispense this material. So first let's look at wax. So wax, if you're doing, you just take the Cavex wax, you place it in a hot water bath and allow it to be molded into a soft stage where you can roll it and make it like a like a template to register the bite. And you should ensure that your wax is very soft. You cannot afford to place the bite registration material, the wax, in the oral cavity after it has set, because this can lead to discrepancies in the occlusal relationships, and it might also increase the vertical dimension. So you have to make sure that the wax is quite soft. So when the patient is asked to bite and you're placing the wax, so in the maximum intercuspation position or the centric relation position, the wax has to show that there are there like what do we say, like you need to see that the teeth are contacting with each other through and through. So there's no wax in the areas where the tooth have come in contact. Suppose if your wax does not show that there are no holes, or meaning there's no through and through connection in the wax. If the wax is intact, that means to say that the wax has already been set, and so when the patient is biting, the wax is hardened, so there is no contact. So this might lead to increase in the vertical. So that is one thing that you have to be very careful. And as we have seen, wax can be subjected to internal stress, and it undergoes rapid changes, and it has to be preserved very carefully. Preferably wax is not used in more comprehensive cases and complicated cases. We would rather use a silicone based material to register the bite. Okay, and the same will be transferred to a semi-adjustable articulator. So occlusion, next, using your occlusal rims, you can record the relationship, right? So you make your denture bases. This is especially for your distal extension. You make a denture base, and yes, always ensure that your denture base is smoothly polished without any rough edges, and also it is very thin. And then you build up your occlusion rim according to the height that you would have observed in the patient, and you carry out the regular jaw relation record like how you would have done for your complete dentures. So yeah, in this slide you can see that the jaw relations have been made using the occlusal rims. I am sure that all of you have taken up complete denture cases, and yeah, in this case when there are no teeth remaining, it is just like your complete denture. And yes, your occlusal rim should be supported with your record basis, that is your denture base should be like intact. They should not be broken. They should be smooth and finely finished so that it does not impinge on the soft tissue. Yeah. So and yeah, for complete denture patients, definitely your wax is the medium of choice, and the method of recording the centric in complete dentures is again dealt as a separate topic. Yeah. And then next, looking at functionally generated path. So this is a very confusing but a very most very important topic. So as you see in this picture, you can see that a cast partial framework is used to record the bite. So as we all know, no matter how many kinds of techniques that we might use to record the jaw relations of the patient, we might end up doing some kinds of errors, or the patient might the patient might not have given you the right bite. So to overcome all these errors, a functionally generated path was developed by Meyer. And if you notice that what they have done is they've taken an impression, and after which they have fabricated the cast partial framework. And in this cast partial framework, as you see, it is seated. The fitting of the cast partial framework is already done. It is placed in the patient's mouth, and the teeth, the area where the teeth have to be placed or teeth have to be arranged, what they have done is they have made space. They have built that area with inlay wax. It's a wax that is used for making wax patterns for your fixed partial dentures. That is what you would have seen in your lab visit, right? Yeah. So this wax is built up on that area where there is an edentulous space, and the framework is seated in the patient mouth. And after that, the patient is asked to bite in centric relation, in centric occlusion, maximum intercuspation, and also move his jaw in all the possible motions or movements. So what happens is when this wax is being placed, it is usually uh, uh, is soft and is slightly in a moldable stage. So when it is in that moldable pattern and it is placed in the patient mouth, and the patient is asked to move his jaw in the centric and eccentric positions, so the opposing teeth that are present will come in contact with this wax, and it will create a pathway. The centric and eccentric movements will create the occlusal pattern for the lower teeth. So this occlusal pattern is used to develop and place the artificial teeth in the lower cast partial framework. So in this, you are not depending on your skills of asking the patient to bite in centric. You would have had a lot of difficulties in guiding the patient to bite in his centric, right? Because once a complete denture patient is, completely edentulous for quite a good amount of time, what happens is the patients lack the neuromuscular coordination. So even in spite of guiding the patient to bite in his centric, he might give a certain glide, and there might be errors in occlusion, which you might not be able to see in your try-in stage. But when you give the patient the final denture, the complete occlusion or the bite of the patient might change. So to avoid all those errors, we are using functionally generated path. It is most commonly used in your fixed partial denture processes, but yes, it can also be in your cast partial. So mounting on the articulator, it's quite simple. So you can either do arbitrary mounting, or you can do mounting with the help of a face bow. Face bow again in itself is a separate topic which will be explained very detailed. So in your arbitrary mounting, what you have to make sure is that once you have positioned your cast as seen in the picture, right? Once you know that this is how the opposing teeth are occluding with the lower teeth, you must secure it in this position. That is, you should either use sticky wax and secure it with help of either rubber bands, or or just use some tape to secure it in that position, and then you have to go ahead with the mounting, because the cast might also change while doing the mounting. Facebook transfer. So in your Facebook transfer, what happens is it relates the maxillary cast, your maxillary cast, to the opening and closing axis of the articulator. So you're transferring the relationship of the maxillae to the articulator with the help of your face bow. It also helps in establishing the correct horizontal plane, and whatever face bow you are using, you should ensure that this face bow is compatible with the kind of articulator that you're going to choose. So based on your selection of articulators, there are a lot of articulators, a lot of complicated, comprehensive, right from a non-adjustable articulator to a highly adjustable articulator. And moving towards technology, we also have the virtual articulators. Right now we are in the most technological phase of the world, so like everything is virtual, right? Yeah. So in your non-adjustable articulators, if you have a Kennedy's class 3 situation and your functionally generated path, if you have used the cast partial framework to do a FGP, then you can mount it on the non-adjustable articulator. If it is a Kennedy's class 1, 2 or 4, you must mount it on a semi-adjustable articulator. And if it is a occlusal rehabilitation, like a full mouth rehabilitation case scenario, then you must use a highly adjustable articulator. And the names of the articulators, how they function, what are the different parts of the articulators, everything will be discussed in detail in your next lectures. So you should be mindful. So as you see that articulator is a must and should. So don't come and ask us doubts, ma'am, should we mount this case? Do we need to do a mounting or not? Yeah. Yeah, and then next coming to moving on to the selection of the denture teeth. So usually the choice of materials, it's acrylic resin denture teeth, then your porcelain denture teeth, and moving towards improvement in aesthetics, we have glass ceramics and also composite materials, but they are more subject to wear of the opposing natural dentition. So they're preferably we try to use your acrylic resin denture teeth, right? Yeah, so as mentioned, yeah, these are the advantages. They are more resilient, they're wear resistant, um, they also have good superior aesthetics, they are easy to adjust, and they're also polished with very little effort. Okay, but the only problem is the disadvantages, that is they have a very low abrasion resistance, and the proper function of occlusal relationship must be checked more frequently because of the wear and tear that keeps happening. The occlusal relationship itself might be hampered, so you might have to do a recall continuously. Yeah, whereas in your porcelain denture teeth, if you see that there are different advantages and disadvantages for the porcelain teeth also. So high abrasion resistance, if you have porcelain teeth opposing porcelain teeth, it's a good thing to do. And yes, nothing will happen to the opposing tooth, so then it will have minimal wear. And then aesthetics, and you will attain the best aesthetics when you're using porcelain denture teeth. And because these porcelain teeth can be similar to that of the porcelain that you used in your fixed partial dentures, whereas your acrylic teeth, definitely they're not so superior when compared to that of the porcelain teeth. But what are the disadvantages is that it's quite unnatural to the patient because you hear more of clicking or the crackling sounds when porcelain rubs against your natural tooth or and opposing porcelain teeth also. And if there are any errors, it is very difficult to recontour and polish. Yeah, so if there is any occlusal error and if you have to do selective grinding, you see that there are premature contacts. Once you have removed the glazed surface of the ceramic, again everything has to be sent back to the lab and it has to be reglazed. So that's quite a cumbersome procedure, right? Yeah. So then coming to arrangement of anterior teeth. So anterior teeth usually it should be selected based on the manufacturer's guide. So you have a shade. I actually have never observed you guys using the shade guide to select the shade for your removable partial denture patients or your complete denture patients. So you must put an effort to take the shade guide that you guys have in the department. You must look at the patient's complexion and try to match the shades. The different kinds of shades that are available, you must make use of them, and you must use the best possible shade that can be possible, that can be available for you. And also your shade selection first, it should be done in your natural light. And yes, so if you would have observed in your teeth sets that you receive, they have different size, they have different shape, and each tooth itself also has different surface characteristics. So you should be mindful about which tooth you are using, which size. They are all coded. You can see something called as S, you can see something called as T, so square, tapering. You can see something called as R, which is for round. So based on shape of the face, that is, we have four main different shapes that we see: square shape faces, tapering shape faces, square tapering faces, and ovoid faces. Based on the shape of the face, you are going to select the shape of the teeth also. Yeah, so that is why the mold selection is very important, and it has to be based on the teeth selection has to be based on the face of the shape. So then coming to your mold selection, so in your mold selection, the space that has been created by tooth loss. So in your edentulous site, once the tooth has been lost, the amount of time for which the edentulous space has remained like that, meaning it can be just a year, like it can be from like few days to few years or to many years. So that edentulous space can be invaded by the adjacent two teeth from the mesial and the distal sides. So the tooth might move into that place, and what is the amount of space that you have over there. So based on that, you have to see which is the size of the tooth that you are also going to use to replace. And especially if you're replacing the anterior teeth, please ensure to cross check with the exterior shape of the face, and that is the kind of mold that you are going to use for the teeth selection and overall form or shape of the tooth. And then coming to your arrangement of the posterior teeth. So as you see, they should fit in the edentulous space. The kind of posterior teeth you use, the mesiodistal dimension and the buccolingual dimension of the artificial teeth are usually smaller when compared to your natural dentition, definitely. So that is why we try to maximize and use molars. Suppose if you are trying to replace the posterior most teeth by using wider and larger teeth, you are trying to expand the width of the occlusion table. So that is why you need to see which is the mold or which is the size of the teeth that you are using, and it should also fit in that edentulous space. So if you are taking a very small teeth, if you say that you don't have the exact size of the teeth, and if you're using smaller teeth, what happens is this creates a gap between the natural tooth, adjacent natural tooth, and the denture, and that leads to an unesthetic appearance and also accumulation of food, and you might not be able to achieve a harmonious occlusion with the existing natural dentition, right? So whatever teeth you're going to use to replace the edentulous space, they should be having a contact with that of the opposing teeth. So some basic important landmarks for your anterior teeth, your incisor papilla and labial vestibule. Then for your occlusal plane in the lower is your it's your retromolar pad, the parotid gland, and the commissure of the lips. That's what you all will be learning in your jaw relations. Then landmarks for your posterior teeth is your maxillary tuberosity and the retromolar pad area. Then coming to occlusion in complete dentures. So I would like to just brief you on some main important topics. So the first one is the different concepts of occlusion. So mainly there are three different concepts of occlusion, that is your spherical concept of occlusion, organic concept of occlusion, and neutrocentric concept. So in your spherical theory of occlusion, this was mainly given by Monsoon, and this concept was derived derived by I think Wants P. Yeah, Wants P, and this is based on the positioning of the teeth with anterior posterior and the medial lateral inclines in harmony with the spherical surface, sometimes referred to as that of the monsoon curve. So in my lecture notes, I will also upload certain pictures related to this, so you can have a look at that. And then coming to organic concept of occlusion, this was introduced by Thompson. And in this, what we need to make sure is that your centric relation position and your maximum intercuspation are coincident, and the posterior teeth are in the cusp-fossa relation, and one tooth to one tooth contact is established. And yes, each functional cusp of the uh, maxillary jaw should come in contact with the occlusal fossa at least 3 points. So when the patient is biting, there should be 3 point contact. So that is your organic concept of occlusion, right? So yeah, and then next coming to your neutrocentric concept of occlusion. So in this, what happens is we are trying to eliminate all the inclinations. So if you look at your natural teeth, your artificial teeth, you notice that the semi-anatomic teeth or the anatomic teeth, they have inclines, right? The cuspal inclines. The cusps have different shapes. So in this concept, what they try to do is they're trying to neutralize all these inclines. They eliminate all the inclines and change the orientation of the occlusal plane. So based on the compensating curve and the incisal guidance, and there's no cuspal angle as such in this concept of occlusion. Yeah. And yeah, occlusal schemes, they've been classified as either neutrocentric, lingualized, monoplane occlusion, linear occlusion, and balanced occlusion. So you've already looked at neutrocentric occlusion. So then coming to your monoplane occlusion, monoplane occlusion is about using non-anatomic teeth. So in cases where there is severely resorbed bridges or patients who have the manual dexterity, to use their dentures, and patients who are mentally challenged, in these kind of cases we try to give a monoplane occlusion. So in this, what happens is either in your balancing position, in your centric and in your eccentric movements, the teeth that are contacting will not have um, uh, any kind of cuspal angulations. They are more like a flat or a play. They are completely made flat. So the centric relation position or in the balancing side, you will see that um, it, it, they're just gliding over, gliding one over the other. So there's you like the cusp fossa relationship is not seen in this kind of an occlusion. And next, coming to linear concept of occlusion. In this type of occlusion, they are arranged in such a way that the masticatory surfaces of the lower teeth, they are quite straight and long, and they have a narrow occlusal form resembling that of the line articulating with the opposing teeth. So something similar to that of the monoplane occlusion. Um, in my in the Google Classroom, I would like to share some videos explaining to you the different concepts of occlusion. I would like to draw and show you the different concepts of occlusion. So I think it should be clear. Yeah. Then coming to lingualized occlusion. So in your lingualized occlusion, it's like it's just to maintain the aesthetics. So that what happens is your it's just only the palatal cusp of the upper teeth are coming in contact with that of the non-anatomic teeth in the lower. So just to maintain the aesthetic appearance, what they do is they use anatomic teeth, the 30-degree anatomic teeth in the upper arch, and they use non-anatomic teeth in the lower arch. Yeah. Okay, so and then coming to concepts of balanced occlusion. So balanced occlusion, you must be familiar and you must learn about the Hanau squint. And balanced occlusion is either unilateral balanced occlusion or bilateral protrusive balanced occlusion, lateral balanced occlusion. These concepts will be explained in detail when we are talking about semi-adjustable articulators and how the complete dentures are fabricated. The balanced occlusion is used in these concepts. Okay, so this is one thing that you all must know. What are the 5 different factors that will be influencing a balanced occlusion? The inclination of the condylar path, the incisal guidance angle, orientation on the plane of occlusion, the cuspal angulation, and compensating curves. So when all these 5 factors are included in your complete denture fabrication with the help of a semi-adjustable articulator, only then you will be achieving a balanced occlusion. Yeah. So lingualized occlusion I've already explained. So lingualized occlusion, the indications, yes, as I mentioned, high aesthetic demands and also severely resorbed bridges in the mandible and displaceable supporting tissue, that is like when you have a flabby tissue, when there is a already existing malocclusion, and also if the previous denture was given in a lingualized occlusion, then you must give a lingualized occlusion in the new denture as well. Then coming to the advantages. So what are the advantages? It has good aesthetics. So if you are using non-anatomic teeth or 0-degree anatomic teeth, what happens is the cuspal outline of the teeth um, uh, appears flat. So it gives more of an artificial appearance. It does not appear like your regular natural dentition. Whereas if you are using lingualized occlusion, as I mentioned to you, so when you're using anatomic teeth in the maxillary arch and non-anatomic teeth in the mandibular arch. The maxillary teeth are more visible, right? When you smile, when the patient smiles, the maxillary teeth are visible and not the mandibular teeth. So it improves the aesthetics. And yes, it has a potential for bilateral balance. It centralizes all the vertical forces. So when the patient is biting, all the forces are accumulated in the and they are directed in a vertical direction, so in a straight way, so open and close movements. So this reduces the tipping forces also, and also facilitates in the bolus penetration. Yeah. Next, then causes of error in occlusion. So what can happen? What are the different things that will happen when there are errors in occlusion? First thing, your state of health of TMJ. So I know that I mean, as undergraduate students, we all try to just overlook the centric relation position. So that is the most important thing. So when you're recording the jaw relations, you must be mindful of the centric relation position. That is you're taking care of the TMJ. Always remember that occlusion is not a static concept, but it's a dynamic concept involving a lot of other anatomical structures, just not your teeth alone, but also your mandibular jaw movements, right? So in if we are not able to maneuver or manipulate the patient to bite in his centric record, there might be an error. So when you so even with great difficulty, after you have recorded the jaw relation, while transferring to the articulator, slight movement of the jaw relation position can also lead to errors. Then failure of seating the occlusal rims correctly on the cast. So if your denture base would have undergone polymerization shrinkage, and if you're unable to seat the denture base correctly on your cast, it might increase the vertical dimension. Yeah, and also the occlusal rims. If suppose your occlusal rims are also unstable and they are not secured on the denture base, that will also lead to errors. Yeah, ill-fitting temporary denture bases, your temporary bases. So if the temporary denture base that you're using in the patient mouth, okay, to avoid any kind of damage to the cast, we try to block out the undercuts, and we end up doing more or excessive block. This might lead to unstable denture bases. So when there is unstable denture bases, because you know the tongue is very powerful, and every time the patient keeps moving his tongue to the right or to the left, what happens is the denture bases will be lifting up from their position. Or if it is in the maxillary denture, if you have overextended or underextended, it might keep falling. So when these temporary denture bases are unstable, your jaw relation also will go for a toss. So that's why you should be very careful. And then looking at use of Facebook, as I mentioned, you are relating the position of the maxilla to the skull base. So that is why use of Facebook is always a must. Then if you are not arranging the posterior teeth in the correct way, then failure to close the flasks incompletely. Yes, so flasking, the processing procedure is one main important thing to achieve a harmonious occlusion. If you have not closed your flask properly, or if the teeth have been displaced in the flasking, so you have closed the flask tightly, but you have used excessive pressure, what might happen is the teeth in the mold might also get displaced, so that can also lead to errors. Yeah. So, what can be done to correct the different kinds of occlusal disharmony? So, we've already seen what are the different errors. So, it can be either chair side or laboratory side. So, if you are looking at your chair side, it is the help of articulating paper. You use a carbon paper or central bearing devices, occlusal wax or abrasive base. Try to mount. First in your lab site once you have achieved. So what we would advise here is, once you are trying to demount your cast from your articulator, try to demount it in such a way that your plaster remains on the articulator, and you just receive your master cast. So when your plaster is just remaining in the position in the articulator, once you have finished the processing, you should try to articulate both your upper cast and the lower cast on the articulator, and then you will be able to see the amount of occlusal errors that could have come in your processing. So by using the existing articulation, the previous articulation, you can try to minimize the chair side time, remove all the premature contacts and all the irregularities. Everything can be corrected in the lab side, and then the denture can be delivered to the patient in lesser chair side time. So if it can be corrected, then the occlusal errors that we might see in the patient mouth will be very much minimum. So even after doing this procedure, if you're still unable to overcome the occlusal errors, then you might have to retake the entire bite and redo the entire lower denture, because that might be because of not recording the centric relation record in the correct way at your jaw relations. Yeah, and then the problems due to resin occlusion. Your denture instability, yes. So in your denture instability, the different kinds of conditions that might contribute for the instability is the last lower teeth is placed more posteriorly, as I mentioned. So never try to place a molar tooth on the steep or inclined plane of the lower jaw. Then orientation of the occlusal plane is not parallel to the ridge. So if your occlusal plane is not parallel to the ridge, there should be parallelism between the teeth that are arranged and also the ridge. Then uneven initial contact, that is your premature contact. The denture, when the patient is biting, the patient brings his jaws into contact in one particular point, and he tries to glide. So there is an uneven initial contact. There's no simultaneous bilateral contact. Then intercuspal position and centric relation, they do not coincide. So as I mentioned to you, your centric relation position and MIP, maximum intercuspation position, should be correlated with each other in your partial dentures. Then excessive vertical overlap of anterior teeth and lack of balanced occlusion. Yeah, and the discomfort. So one more error, it causes a lot of discomfort to the patient. So the patient will complain of pain in the presence of occlusal imbalance. So if your patient is coming back and complaining that he has pain, what are the different things that you will have to look at? First thing, occlusal imbalance. Then you have to remove the complete denture from the patient mouth and observe if there is any ulceration on the lingual aspect of the lower anterior ridge or labial aspect also. And if there are any rough irregular surfaces on the undersurface of the denture, or if the denture is overextended in the distal lingual sulcus or in the maxillary tuberosity region. So overextensions have to be checked. If the patient complains of continuous dislodgement of the denture in the anterior when he's speaking, so that means there is insufficient labial frenum relief. So that is what you have to check for. And pain in the periphery. So when the patient might show his finger towards the maxillary tuberosity region or towards the distal lingual sulcus or towards the retromolar pad. So that means the patient is experiencing pain in the depth of the sulci. That is because of overextension of your flange. So your bottom already would have gone for a toss in that particular area. So then you have to correct the overextension. Then the patient might complain of also cheek biting and lip biting. So what happens in cheek biting and lip biting is your posterior, upper posterior teeth were not placed on the ridge, but they were pushed too buccally. So that causes a cheek bite. Then tongue biting. So tongue biting happens when you have tried to place the lower teeth too lingually, which cramps up the tongue in the space that is given, and so it leads to tongue biting. Yeah, and also soreness on the crest of the ridge. So there must be a good amount of relief that must be given on the crest of the ridge. And yes, as I have discussed about the different kinds of occlusion, concepts of occlusion, if it is a severely resolved ridge, then definitely you must consider giving a monoplane occlusion. And also the type of teeth that you're going to use, that is your semi-anatomic teeth or anatomic teeth or non-anatomic teeth, based on the anatomy of the ridges, the residual ridge has to be taken into consideration. Yeah, so these are the things that the patient will complain of. So this is what you can look at when the patient has come back for the review. And yes, as mentioned, I hope that you will be able to rectify these particular errors when the patient comes back to you. Yeah. Yeah, so that's all for today, and thank you guys for patiently going through the lecture. I hope the concepts were clear. And yes, I know occlusion, the different concepts of occlusion are quite confusing, but I'll try to upload and share with you a video on these concepts of occlusion in our Google Classroom. So please do go through it, and yes, please feel free to just comment or discuss any kinds of doubts in regards to occlusion in removable partial dentures. And I hope that you will be able to go through the lecture. And please remember that definitely this is a very important topic for all of you. Thank you.